So moving on to ADH antagonists, still in chapter 25. Antidiuretic hormone antagonists. So if we're thinking about these words, antidiuretic means not to diurese. And if we are antagonizing that, essentially it's a double negative. So we're canceling out that not diuresing, and we're going to go ahead and get rid of water. So it blocks the ADH receptor in the kidneys, and inhibition of ADH receptors causes excretion of free water without electrolyte loss. So we're not worried about our sodium or our potassium. Conivaptan is the first ADH receptor antagonist approved for use in patients to conserve sodium and water. Conivaptan antagonizes ADH receptors in the collecting ducts and again gets rid of water without disturbing the electrolyte balance. This class of medications isn't used quite as often. It's usually used in patients in which hyponatremia is a concern, but they aren't swollen with a lot of excess fluid. So, miscellaneous diuretics. Xanthine derivatives are naturally occurring drugs such as caffeine, pamabrome, theobromine, and theophylline, and they have a mild diuretic response. These drugs stimulate urine flow by increasing the blood flow through the kidneys, resulting in increased glomerular filtration and urine formation. Most often they're used in combination with other diuretics. Side effects include CNS stimulation, hypotension, and headache. Special considerations on slide 23. Most diuretics cause that electrolyte and acid-base imbalance that we talked about. So we monitor their labs and we adjust as needed. Blood pressure can also be altered because once we start getting rid of volume, there's a lot less pressure on the vascular system, which means blood pressure is decreased. And we don't want to lower that too low because we could cause a patient to faint, have orthostatic hypotension, etc. And last but not least, we're keeping an eye on our blood sugars for our diabetics because blood glucose levels may be altered. Slide 24, drug interactions and incompatibilities. Diuretics are never mixed in IVs with other medications because they can precipitate out. In addition, they're involved in a number of drug interactions due to their mechanism of action. Alcohol, antihypertensive drugs, barbiturates, opioid analgesics, they all increase the possibility of orthostatic hypotension when taken with thiazides and loop diuretics. Let's see. So we don't ever mix them. Preferred treatments. This is always a fun slide. It kind of gives you a wrap-up of everything we've just talked about. ADH antagonists are indicated for the clinical management of euvolemic and hypovolemic hyponatremia hospitalized patients. These are IV medications that are only going to be used in that situation. Carbonic anhydrase inhibitors are useful in glaucoma, edema with alkalosis, which is a blood pH that is alkaline, as well as mountain sickness. Loop diuretics are used in pulmonary edema, peripheral edema, hypertension, acute hypercalcemia or hyperkalemia, and acute renal failure. Thiazides are the preferred therapy in hypertension, heart failure, as well as a couple other kidney disorders. Osmotic diuretics are used to improve renal failure due to increased load, such as rhabdomyolysis or chemotherapy. It's also used to reduce increased intracranial pressure and remove fluid and reduce pressure in glaucoma. And potassium-sparing diuretics are used in hyperkalemia in addition to other diuretics to balance out the potassium lost, as well as sometimes post-myocardial infarction, post-MI. I'll do chapter 26 in a separate video, and just stay tuned.